What if I told you 3 patients with stubborn ankle foot pain recovered in only 6 visits without relying on strengthening or fancy modalities? Most of the diagnoses you get with the ankle are pathoanatomical, meaning you'll have posterior tendonitis, plantar fasciitis, ankle sprain, but there can be conditions that can mimic these issues in the foot that are often missed, leading you down a path of frustration without lasting results. And that's what we're going to talk about today. In 2018, in the Journal of Manual and Manipulative Therapy, there was a study that looked at the application of mechanical diagnosis and therapy to the ankle and foot complex. And there was a case series. So today I'm going to break down how these principles can apply to the ankle and foot complex, what directional preference means here, and what outcomes they were, and what were the lessons that we can learn from the patients to take this home. So we always say where the side of the pain is often not where the source of the problem is coming from. You have to check out mobility before you can start working on stability. And you have to look into issues that are tendonitis and plantar fasciitis that look like that, but in reality, it's a lack of joint movement that's creating some of those issues. We call this a joint derangement. Joint derangement refers to a disruption or abnormality in the structure and function of the joint. It is rapidly changing, meaning that we can get quick results if we use the right loading techniques and direction. By the end of this, you're going to understand the beginning stages of like an MDT evaluation and classification. You're going to understand the special loading strategies that you can use, why these results raise provocative questions about the conventional rehab logic. So let's get into some patient examples. So we're going to go through 3 different patient scenarios based on this research. And I love this because you're going to be able to see kind of our thought process and how we go about things differently. And, you know, we always say like mobility before stability, and this is that mobility piece, and it's a piece that is missing. And if you're someone that is frustrated because you have this diagnosis, if I go in and I treat a diagnosis, I'm not gonna, I don't care what the diagnosis is. We need to go and see how everything is moving, and more than likely something like that is causing something that mimics this. So the first case that we're going to talk about is a runner who did some high impact activities and kind of landed on her ankle wrong. She thought she had an ankle sprain, but it just wasn't resolving, and she couldn't get back to running, and that was a problem. And so what we found, or what they found in this research, was she was very limited in range of motion. So she was limited in dorsiflexion, which is pulling the foot back, like that's dorsiflexion. She was limited in plantar flexion, which is pointing those toes down, and she was limited in inversion. So she was limited going in this direction. Now, when you have someone, if they have a typical ankle sprain, it's really common to have what we call these derangements, where there's joint material that just kind of gets displaced because it's a forceful motion. And so she probably had that happen, kind of a little shift or something, and you get some of the joint material just kind of gets displaced essentially. And so that's where we're in this evaluation process, we're looking at like finding a motion that's going to really open it up. When you have an ankle issue, a lot of time dorsiflexion, because how do you sprain your ankle? Plantar flexion and inversion. And so that's how you do it forcefully usually. And so a lot of times dorsiflexion will solve it. Sometimes dorsiflexion with eversion, taking them in the opposite direction. So they plantar flexion and inverted, we'll take them into dorsiflexion and eversion. But for this case, they went and they did loaded dorsiflexion. They started out with that because we want to kind of start out in the sagittal plane. That's the front and back plane. That's the movement. Any movement through here that's moving forward and backward is a sagittal. Anything that goes to the outside is more lateral. And so we exhaust that plane, and you can do these exercises that I'm going to show you loaded, which is how they did it, and it worked. And you can do them unloaded. Sometimes you have to do them unloaded, which is basically pulling your foot up and you're not putting weight through it, but you're just kind of pulling that foot back. That is unloaded. When you put any weight through it, it's loaded. Now I'm going to show you how to do what we talked about up here, how to do it. But they show it on the ground, and you can do it on the ground. This is just a partial loaded way of doing it. So you have dorsiflexion, so you have your foot through here. And what you're going to do is you literally lean forward, and you're just trying to get this part of the foot to come up through here. You're just trying to mobilize that joint in through there. So you just do this. Now, obviously, the foot doesn't come all the way to the top. So this is kind of what they started out with. You can do the same thing where you do this on the ground, and you put your foot up on a step, and you can bring that foot below the step and load into it. And this is just another way of doing it. And so that's what they did. They got some improvement, but it kind of plateaued. So that's when they added eversion. So you can use a little towel roll, and what you're going to do, because of that foot, you're going to put the foot partially on the towel so it rotates. I'm going to show you the other way. So I take my foot here, you have the towel, and you put half the foot on it. So you can see how the foot will drop to the outside, and then you're going to do the same thing where you just load it. You're coming in and you have it slightly rotated to the outside, and then you're coming forward. You're trying to get the front part of the foot to go to the top to the shin. It doesn't get there, but that's the motion that we're trying to get. So you're pushing down and you're going forward. And so that's what they did with this first case, and then that solved it. And they had great results, and they were able to get back really quickly. Because again, derangements are rapidly changing. That's how we can find things that may mimic a condition, but we can rule it in and rule it out really quickly, which is really the key. And so when we look at our evaluation process, there's a word called directional preferences. There's one direction that'll open up all the other motions. So like we only went into dorsiflexion with some eversion, and that opened up plantar flexion, that opened up inversion, that opened up dorsiflexion, opened up all of it because we're just trying to get everything to move correctly again. And so that's what directional preference is there's one direction that will open up all of it. And it's just trying to figure out what that is. And that's kind of the process that we go through and we see all the time. So now the second case is a little bit different. It was a 77-year-old female that had posterior tib tendonitis. So posterior tib is a muscle that comes through here, and it goes in and attaches into the bottom of the foot. It actually helps hold up that arch. And so there was no trauma, there wasn't anything, she just started hurting one day. And so again, that doesn't really make sense for a posterior tib tendonitis. And so you're putting all these pieces together to figure things out and going like, that doesn't make sense for that, that doesn't make sense for that. But we're always looking to rule out, again, mobility before stability, looking to look at how does the joint move. Well, in this particular case, she was having a hard time walking and putting weight on it, and it was painful for her to pull her toes up. So she couldn't pull her toes up without having a lot of pain. So they started out with repeated dorsiflexion, which is what we just showed you here, where they came in and they did that. There was no effect. Okay, great. So we want to stay in, again, the sagittal plane, so they did repeated plantar flexion. So how you do repeated plantar flexion is you take the foot, you're going to push it down, and you just kind of push into it. So you're pushing it to go as flat as possible. So they did that. If you need a little bit more motion, you can put your foot up like this to go a little bit higher so you can go farther into that motion. So some people have a lot more motion, and you might have to do this to get to end range, but essentially that's what they did. And that, again, it helped a little bit. They could tell that it made some improvements, rapidly changing improvements, but it didn't fully solve it. So when you exhaust the sagittal plane, then we want to go lateral. And so that's what they did. So they took it and they did eversion as the lateral. So again, they did this in weight bearing. We're doing it in weight bearing, but in a slightly different way, not as much weight through it. But your foot is going to be angled so that the foot angles to the outside, and you're doing the same thing, but you're just trying to literally weight through it, but at an angle. You can do this in standing too, and that gets even more weight. So if you do it in standing, it's going to be the exact same position, but you're just going to add weight onto it to mobilize that joint. And when they did that lateral motion like this, everything resolved. Dorsiflexion improved, they're able to walk, no problems. It just shows you that it's a joint issue. And so again, a little bit of a different scenario, a different direction, It's why it's so difficult to go and say, oh, you do this for this, because in an evaluation, how your body responds and is basically how it guides us through the whole process of what we need to do next. So whether it gets better, it gets worse, or stays the same, it all gives us information to understand your body. And that's why it makes it hard to go and like, okay, for videos, if you have this, go and do this. If you have posterior tendonitis, go and do this. Well, is it really that, or is it something else? You don't know. And so this video is just trying to help us go through some of those things. Okay, so the last one that we're going to talk about in this research, they did 4, but we're going to talk about 3 of them. It was a 72-year-old female who basically was getting second toe joint pain. A podiatrist had sent them to this particular office that did the research, and when they were questioning her, she had a history of back pain. And so you have to rule out the back, because the back can refer pains all the way down the body. And you can have weird nerve things that are happening. It's that you don't feel anything in the back, or maybe you have some stiffness, but you feel like that's just normal as we get older because I'm a 72-year-old female. But in reality, that can cause a lot of issues down in the leg. And so they just started out with loaded standing extension. So like we find like when women and males are older, they tend to do better in standing doing this, and when they're really stiff. So if they're really stiff and older, then they just did repeated back extension. You can do it over counter. You can put your hands where you're putting them literally into the lower back, and then you're just extending back and then coming up, and then extending back and then coming up. So she literally did 15 of those, and her toe pain went away. So it was actually really coming from her back. And so these are 3 very different scenarios that give you a different picture of where the pain and the problem is actually coming from, which is not at all where the source of the problem actually is located, which is why you hear us say this all the time, over and over again and again. It's because that it's true. Like the way we look at the body and our evaluation process is so different than most people's evaluation process. And it's why we get the results and figure out the body and figure out where things are coming from, because of ruling things out and listening to the story and understanding kind of what's going on to give you the best outcome. So if you're someone dealing with foot and ankle issues, this talk invites us to reconsider some of the assumptions about what's wrong and how to treat it. If you found this breakdown helpful, hit the like button and subscribe so you don't miss future content. If you are suffering with ankle pain, back pain, knee pain, and you haven't found a solution yet to your problem, comment below. Tell us more about what's going on, what you've tried, what is working and what is not working. If you'd like to learn how you can work with us and you live in the DFW area, click on the link in the description called Discovery Visit, and we can start that process today.